Your mother is 72 years old. She falls, breaks her hip, and is rushed to the hospital by ambulance. The hospital is the one her Medicare Advantage plan covers. The surgery goes well. The doctors seem competent and attentive. 3 weeks later, an envelope arrives in the mail. Inside is a bill for $1,400 from a physician she has never heard of. She does not recognize the name. She does not remember this person ever entering her room. Or picture this. Your father spends 4 nights in a hospital bed after chest pain and fluid around his lungs. He has a dedicated care team. He sees specialists. He assumes he is admitted as a patient. When he is discharged and your family calls to arrange rehabilitation coverage, Medicare tells you it does not apply. He was never formally admitted. He was under something called observation status the entire time. The rehabilitation bill arrives. It is $22,000. These are not edge cases. They are not rare mistakes made by overwhelmed systems. They are patterns. They happen every single day in hospitals across the United States to people who did everything right, who chose their hospital carefully, who thought they were covered, and who simply did not know the right questions to ask. My name is Dr. John Carter, and today I'm going to give you the 5 sentences that could protect your retirement savings and your recovery the next time you or someone you love walks through a hospital door. Let me be clear about something before we begin. The problem I am describing is not primarily about bad doctors. The physicians inside most hospitals are doing their best under genuine constraints. The problem is the system built around those physicians, a financial and administrative structure that creates traps that are legal, largely invisible to patients, and extraordinarily costly. The people who fall into these traps are not careless. They are not unsophisticated. They are people who simply were never told what to watch for. By the end of this conversation, you will know exactly what to say. Trap number 5. The out-of-network specialist surprise. This is the trap that catches more people off guard than almost any other, precisely because it happens after you have done everything right. A senior does their research. They call their Medicare Advantage plan. They confirm their chosen hospital is in-network. They feel prepared. The procedure goes smoothly. 3 weeks later, an envelope arrives with a substantial bill from a physician whose name they do not recognize. The hospital was in-network. The building, the facility, the operating room, all covered. But the anesthesiologist who administered sedation, the radiologist who interpreted the imaging, the emergency physician who assessed them on arrival, each of those doctors may hold entirely separate network agreements from the hospital itself. If any one of them is contracted outside your plan's network, the financial responsibility for their portion of your care falls directly on you. And no one at intake told you this was possible. This practice has been ongoing for years. It exploits the gap between a patient's reasonable assumption that a hospital in-network means all care within that hospital is covered, and the legal reality that each physician practicing in a facility may be a separate entity with separate contractual arrangements. Here is what changed this equation significantly. A federal law called the No Surprises Act was passed specifically to address this situation and gives you a protection that almost no one uses because almost no one knows it exists. The moment you arrive at any hospital, before any procedure begins, before any specialist enters your room, you have the right to say the following words to the intake staff or the billing department. I only consent to treatment by in-network providers under the No Surprises Act. Those 15 words put the hospital on formal legal notice. If they subsequently bring in an out-of-network specialist after you have made that statement, the financial responsibility for that specialist's services shifts back to the hospital, not to you. Write those words down right now. Put them in your phone. Commit them to memory. Because the moment a hospital knows you are aware of your rights under this law, the entire dynamic of the financial conversation changes. I want to ask you something here. Have you or someone in your family ever received a medical bill weeks after a hospital visit that made no sense? A charge from a physician you have no memory of seeing? If so, leave that experience in the comments. Someone else reading this right now may be in that exact situation and have no framework for understanding what happened to them. Your account may give them the clarity they have been searching for. Trap number 4, premature discharge. This trap operates differently from the others. It does not involve paperwork. It involves a rushed conversation at your most vulnerable moment. Hospitals face genuine financial pressure from insurance companies to move patients out of beds as rapidly as possible. In practice, this pressure sometimes translates into discharge decisions that prioritize institutional financial efficiency over individual patient readiness. A physician enters the room and says the words that carry enormous authority in that context. "You are doing well enough to go home." And because it is a physician saying this, most people accept it without question. They get dressed and they leave. 3 days later, the wound is not healing properly, or they fall getting out of the shower, or they are back in the emergency room, which ultimately costs 5 to 10 times more than the additional hospital days that were cut short. This pattern is sometimes called premature discharge, and it falls hardest on seniors whose recovery margins are narrower and whose home environments may be less equipped to compensate for care that was not completed. Here is what most seniors are never told. Medicare patients have a legal right to appeal a discharge decision they believe is premature. That right exists right now in federal law, and it is almost universally unknown among the people it is designed to protect. Here is how it works. If a hospital tells you it is time to go home and you or your family do not feel you are medically ready for that transition, you can request an expedited appeal through your local quality improvement organization, commonly called a QIO. You can locate yours at medicare.gov. Once that appeal is formally filed, the hospital cannot legally discharge you while the review is being processed. You are protected by federal law during that window. The words you say to your care team to initiate this are straightforward. "I do not feel medically ready for discharge, and I am requesting an expedited appeal through the QIO." Let me share a story that illustrates what is at stake. A woman I will call Margaret was 71 years old and had undergone a hip replacement. On the second day following surgery, a physical therapist came in, conducted a brief assessment, and by that afternoon, her physician was suggesting she go home the following morning. Her daughter, who had learned about the QIO appeal process, asked the nurse a simple question: "Can we speak with the case manager about requesting a QIO appeal?" The atmosphere in the room shifted noticeably the moment those words were spoken. The discharge was postponed. Margaret spent 2 additional days in the hospital completing her physical therapy baseline requirements. When she eventually returned home, she said something that stayed with me. She said she was certain she would have fallen on her first night home. Certain. That daughter's knowledge of 5 specific words changed what happened next for her mother. Those same words are now available to you. Trap number 3, unauthorized medication substitution. This trap begins before you ever think to be on guard, during the early hours of an admission when your attention is divided and the medical team is moving quickly. Every hospital operates an internal pharmacy built around what is called a formulary. This is the facility's approved list of medications it stocks and dispenses. The maintenance medications you have been taking for months or years, carefully calibrated by your personal physician, adjusted over time to achieve the specific therapeutic balance your body requires, may not appear on that formulary. When a hospital pharmacy does not stock your exact medication, the standard response is substitution. A different brand, a different generic formulation, a different equivalent. Sometimes this substitution is communicated clearly to the admitting physician. Sometimes it is not, and it is rarely communicated directly and explicitly to the patient. For adults over 60, this matters considerably more than it might for a younger patient. The cardiovascular system in particular is sensitive to medication changes in ways that can produce real and measurable adverse effects. Blood pressure instability, cardiac rhythm irregularities, dizziness that creates fall risk. These are not hypothetical concerns. They are documented consequences of abrupt medication changes in elderly patients. And beyond the health dimension, the hospital pharmacy typically charges premium rates for the substituted medications, meaning the patient pays more for something that may not be the therapeutically equivalent option their clinical history calls for. The protection here is straightforward and can be prepared before you ever need it. Maintain an updated written list of every medication you take, including the exact brand name, the precise dosage, and the specific timing. Carry a copy with you at all times. When you or a family member is admitted to any medical facility, hand that list directly to the admitting physician and say clearly, "Do not substitute or alter any of my maintenance medications without an explicit clinical review and my written consent." Those words establish your expectations at the point of admission, before substitutions can occur rather than after. They place the responsibility squarely on the clinical team to flag any proposed change to you before it happens. This is not unreasonable. It is your right as a patient and as the person responsible for your own healthcare decisions. Trap number 2. The blanket financial responsibility form. This is the trap that financially blindsides more seniors than any other on this list. And the devastating irony of it is that most people sign away their protection in the first 10 minutes of being in the building, at the precise moment when they are most frightened, most distracted, and least equipped to read carefully. Walk into any hospital in America for an admission, and within minutes of arrival, someone places a clipboard in your hands. The stack contains consent forms, privacy notices, insurance authorization documents, and somewhere in that stack, sometimes on its own page and sometimes embedded within a longer document in language that does not call attention to itself, there is a clause stating that you assume personal financial responsibility for any services not covered by your insurance. Most people sign it without reading it. They sign because they are in pain, because they are afraid, because a procedure they need is waiting, because someone is standing there expecting the clipboard back. The signature happens in seconds. What that signature can authorize is the hospital's legal right to bypass the negotiated rate process entirely and bill you directly at full non-negotiated rates for anything Medicare or your insurance does not cover completely. This practice is called balance billing. The difference between full rates and negotiated rates can be enormous. Thousands of dollars in charges that your insurer would have reduced to a fraction of that amount through standard negotiation, except you signed away that protection before anyone explained what you were signing. Here is exactly what you do instead. Before signing any financial agreement, write the following phrase in pen next to your signature, not in place of signing, but immediately beside or below it where it will be part of the same document. Signing only for authorized insurance benefits, not personal financial liability for uncovered balance billing. You can write this in front of the intake staff. You can do it clearly and without apology. It is legal. It creates a documented record of your intent at the time of signature. It protects you from that signature being used to justify charges that you never knowingly agreed to absorb. If you have a family member over 60 with an upcoming procedure of any kind, take a photograph of that sentence right now and send it to them today. Print it out and put it with their insurance documents. This is one of the most concrete and immediately actionable pieces of information I can give you, and it takes 30 seconds to share with someone who needs it. Trap number 1. Observation status. This is the trap that changes the financial reality of a hospital stay most completely, and it is the one that the fewest people know to ask about. The story of Robert, which I will share in a moment, is the clearest illustration I know of both the stakes and the solution. According to data from the Centers for Medicare and Medicaid Services, approximately 3 out of every 10 Medicare patients admitted to hospitals annually are classified under what is called observation status rather than formal inpatient admission. That figure represents hundreds of thousands of seniors every single year. Here is what observation status means in practice. A patient classified under observation status is technically an outpatient in Medicare's administrative framework, regardless of where that patient is physically located. Even if they are lying in a hospital bed for 4 consecutive nights, receiving specialist care, undergoing diagnostic testing, eating hospital meals, and being monitored continuously by nursing staff, their administrative classification may be outpatient rather than inpatient. This distinction has profound financial consequences because of how Medicare Part A, which covers skilled nursing facility and rehabilitation care following a hospital stay, determines eligibility. Medicare Part A coverage for post-hospital rehabilitation requires a minimum of 3 consecutive days of formal inpatient admission. Observation status does not count toward that 3-day minimum, not 1 hour of it, not even if the patient spent a week in a hospital bed under continuous medical care. The practical outcome is that a senior can spend 5 nights in a hospital bed, be discharged needing rehabilitation care, go to a skilled nursing facility, and receive a bill for the entire rehabilitation stay out of pocket because Medicare considers them to have never been formally admitted. The bills that result from this administrative classification can exceed tens of thousands of dollars. Robert was 68 years old, a retired electrician from Arizona. He was admitted to the hospital with chest pain and fluid accumulation around his lungs. He had a bed, a care team that visited regularly, a cardiologist, continuous monitoring. He spent 4 nights. By any reasonable understanding of the word, he was a hospital patient. When he was discharged and his wife contacted Medicare to arrange rehabilitation coverage, they were informed that Robert had been under observation status throughout his entire stay. Medicare Part A did not apply. The rehabilitation bill that arrived totaled over $22,000. When I sat with Robert sometime after this occurred, he said something I have not forgotten. He said that no one used those words around him once during his entire hospitalization. Not observation status, not outpatient, not any language that would have indicated his administrative classification was different from what he understood it to be. He said that if someone had told him, he would have asked them to change it. And in many cases, when a patient explicitly makes that request, the status is reviewed and changed. Here is what Robert should have known to say, and what you now know. The moment you or a family member is placed in a hospital bed, ask the attending physician or the case manager directly, am I admitted as an inpatient or am I under observation status? If the answer is observation status, say this immediately. I am requesting that my status be reviewed for formal inpatient admission based on medical necessity. That request is formal. It must be documented. The care team is obligated to respond to it. In a meaningful number of cases, when a patient or family member explicitly makes this request, the status is reviewed and reclassified to inpatient admission. There is also a legal notification requirement that is worth knowing. Federal law requires hospitals to notify Medicare patients of their observation status in writing. This notification is called the MOON Notice, which stands for Medicare Outpatient Observation Notice. Hospitals are required to deliver it within 36 hours of placing a patient under observation status. If you have been in a hospital for more than a day and a half and have not received this document, ask for it by name. Have I received my MOON Notice? Those 5 words communicate to the hospital that you are aware of your rights under federal law. In a system where most patients do not know these rights exist, that awareness changes the nature of the conversation immediately. Now, let me bring everything together with an action plan you can implement today. Take out your phone or a piece of paper right now and write down these 5 sentences. These are your hospital protection statements. They require no legal expertise, no prior medical knowledge, and no confrontational posture. They simply require you to know them and to use them. First, am I admitted as an inpatient or under observation status? Second, I am requesting that my status be reviewed for formal inpatient admission based on medical necessity. Third, I only consent to treatment by in-network providers under the No Surprises Act. Fourth, do not substitute or alter any of my maintenance medications without clinical review and my explicit written consent. Fifth, signing only for authorized insurance benefits, not personal financial liability for uncovered balance billing. 5 sentences. That is your complete hospital protection framework. Save them in your phone. Write them on a card and keep it in your wallet. Share them with every adult in your family, your spouse, your siblings, your adult children managing a parent's care. Commit to carrying this list to every medical appointment for the next 30 days. Review it before you walk in. Refer to it when the moment requires it. Within 30 days, these responses will be second nature. You will not need to think about them. They will simply be part of how you navigate the medical system, the way someone who understands the rules of any complex system navigates it differently from someone who does not. The people who know these 5 sentences leave hospitals with their retirement savings intact and their recovery protected. The people who do not know them leave with bills that no one warned them were coming, for care they did not realize was unprotected, classified under statuses no one explained. You now know them. The next conversation we need to have covers what comes after the hospital. What happens when you are transferred to a rehabilitation or skilled nursing facility, and the financial and medical traps that are waiting there. Because everything we covered today only protects half of the journey. The other half matters just as much. This is Dr. John Carter. Know your rights, use them. I will see you in the next one.